Hello guys, welcome all of you to today's session of Pharmcast. Again guys, today I'll be discussing about 5 different drugs of choice as well as another important concern that we find in our day-to-day lives while preparing for the post-graduate medical entrance examination. And see guys, here let's begin with the first disorder for today is anovulation. And actually guys, for anovulation, what is the drug of choice? It depends upon what is the cause of anovulation. For example, number one, if it is a hypogonadotrophic amenorrhea or anovulation is because of hypogonadism, and in that case guys, the cause hypogonadotrophic hypogonadism is because of what? Is because of decreased release of what? GnRH or gonadotropin releasing hormone. Now here, the better drugs are GnRH agonists like goserelin. Though you can use clomiphene, but clomiphene is not that effective as GnRH agonist. So if it is a case of hypogonadotropic anovulation, in that case go for GnRH agonist. However, if it is a case of anovulation caused by PCOS, polycystic ovarian syndrome, the current drug of choice is letrozole, right, as compared to clomiphene. So clomiphene used to be the drug of choice. The current drug of choice is letrozole because it is much more effective as compared to clomiphene. Third, if it is anovulation due to hyperprolactinemia, in that case guys, your drug of choice is bromocriptine. You won't go for cabergoline here because you are treating the female for anovulation, means pregnancy is desirable. And remember, cabergoline is not preferred in pregnancy because it can cause cardiac valve defects. So I'll revise once again guys, I'll repeat once again. Anovulation, hypogonadotrophic anovulation, go for GnRH agonist like goserelin. Polycystic ovarian syndrome, letrozole. Hyperprolactinemia, go for bromocriptine, right? Moving on to the second disorder for today guys, aortic dissection. See, in aortic dissection guys, we need to decrease the contraction of the heart so that I can decrease the systolic blood pressure. And the drug of choice for that are beta blockers. Two beta blockers which are more preferred are esmolol or labetalol. Now the preferred one is labetalol, but esmolol would be more preferred if you are dealing with a condition where beta blockers can be detrimental. For example, the patient of aortic dissection also has bronchial asthma. In that case, I will rather prefer a shorter acting drug. For example, the patient of aortic dissection is also suffering from heart failure, then I'll go for esmolol. Right, so you'll choose a drug, esmolol or labetalol, depending upon the comorbidities. Now, second part is, if the patient does not respond to beta blocker alone, what is my second line drug? Think guys, think, what is my second line drug? Is it a calcium channel blocker or is it any other drug? So guys, here my second line drug is intravenous nitroprusside. Calcium channel blockers can be used, but they are not second line, they are third line drugs. So you should at least remember the first and second line. So aortic dissection, beta blockers like esmolol or labetalol, these are the drug of choice. If the patient does not respond, then you can add nitroprusside. Remember, nitroprusside should never be used alone in aortic dissection because it can cause reflex tachycardia that can be detrimental. So it is only used as an add-on drug to beta blockers if the patient does not adequately responding, means there is not an adequate decrease in systolic blood pressure. Now moving on to the third disorder for today guys, invasive aspergillosis. Now see, remember, invasive aspergillosis, this is a mistake that most students do. They think amphotericin B is the drug of choice because it is like a nuclear bomb for antifungal drugs, and we tend to drop it everywhere wherever we see a fungus. But that does not work here. So remember, invasive aspergillosis guys, the drug of choice is voriconazole, right? Yes, it's a azole called as voriconazole. So you start the patient on voriconazole, and then for secondary prophylaxis you continue voriconazole. So remember, for drug of choice for treatment is voriconazole, and then we continue, that is secondary prophylaxis, again voriconazole. But if I'm giving a drug for primary prophylaxis, so what is primary prophylaxis? Suppose there is a patient of acute myelogenous leukemia and I'm giving him chemotherapy. So obviously the chemotherapy will cause immunosuppression. The patient might be at risk of invasive aspergillosis. So in that case, for primary prophylaxis, the choice of drug is not voriconazole, it is rather posaconazole. So remember guys, prophylaxis of fungal infection like in bone marrow transplant patients or in leukemia patients where we give chemotherapy, or in patients of GVHD, graft versus host disease. To prevent fungal infection, the drug of choice is posaconazole, right? So, moving on guys to the fourth disorder today, and it is aspiration pneumonia prophylaxis in surgical patients. So surgical patients, they're at high risk of aspiration pneumonia. In those patients, what should be my drug of choice? Now you know that you can narrow it down to two classes of drugs. It is either H2 blocker or it is proton pump inhibitors. But here, PPIs are not the drug of choice, guys. Here the drug of choice are H2 blockers, right? The reason being, see, the cause of post-operative aspiration pneumonia is usually basal acid secretion, and basal acid secretion is controlled by histamine. That is why H2 blockers are more effective than PPIs in controlling basal acid secretion, and that is why in this case, for aspiration pneumonia prophylaxis in surgical patients, your preferred drug or drug of choice would be H2 blockers like cimetidine, ranitidine, etc. Right? Now guys, we have reached to our last disorder for today, that is atrial fibrillation or flutter. Now remember, I'll divide it into two parts: acute attack, long-term management. Acute attack of atrial fibrillation or flutter, guys, the treatment of choice is cardioversion. If the patient does not respond to cardioversion, to improve the response, I add intravenous potassium channel blocker called as ibutilide, because it is the shortest acting potassium channel blocker. So in other words, they can ask you which is a drug that is used for chemical conversion of atrial fibrillation or flutter, then your answer would be ibutilide. Long-term management, there are two concerns in atrial fibrillation and flutter. One is rate control, one is rhythm control. For rate control, I use beta blocker as a drug of choice because I need to block the AV node. For rhythm control, I use amiodarone as the drug of choice. Potassium channel blocker, I need to block the myocardial cells, right? So guys, all in all, atrial fibrillation, flutter, acute attack, treatment of choice, cardioversion, not responding, intravenous ibutilide. Long-term management, rate control, beta blocker, rhythm control, amiodarone. This is what they ask you in your exams, right guys? So we have reached to the last, part of our Pharmcast. And here today I'll talk about something that happened to me as well, also in the preparation. And this is how to deal with over-enthusiastic co-aspirants or friends, whatever you can call them. So I'll tell you guys what happened with me when I was preparing, right? I had a friend who used to read about these rare stuffs in Harrison and other textbooks every day. And in the evening, he used to come to me to find out how my preparation is going on. And then accidentally he would drop these 1 to 2 weird questions that I had never heard or I had never read about. And then he will live with a smile and leaving me sad that I don't know these stuffs. But later on I realized that whatever he used to ask, they never appeared in the exam, none of them, right? So what you need to remember is you should not get depressed by such people or such things. The reason being, guys, most of the MCQs which are asked, they are asked from the common topics or those diseases or disorders which affect majority of the population. For example, if I take the topic of epilepsy, then you should know about generalized seizure like GTCS, myoclonic seizure, absence seizure. You should know about partial seizure. But then you'll find there are weird kinds of syndromes in epilepsy, like there is a syndrome called as Landau-Kleffner syndrome, which is seen in children with resistant seizures and etc. So if you don't know about GTCS or MS or absence seizure, that is a problem. But if you don't know about Landau-Kleffner syndrome, guys, forget about it. You should not know about it perhaps until and unless you become a neurologist, right? So that is what I wanted to tell you guys. Never get depressed by such things. For things which are not common and not repeatedly asked, you can forget about those and focus on the money. The money is on those topics which are frequently repeated. Master them, revise them frequently, and you will get there. So guys, that's it for today, and take care. Bye-bye. This was Dr. Ranjan.